saya Rahmat Budi, Nurse Denny, kemudian Dr. Putria dan juga Dr. Ahmed hari ini akan melakukan prosedur transkatheter PSD closed door. Terima kasih. Delivery kabel dari PSD occluder occlutek ya. Ini terdiri dari kabel, kemudian ini adalah loader ya, dimana kita nanti akan mengaitkan device-nya ke dalam ini ya. Jadi kita bisa lihat di sini gedungnya kita buka. Ya. Kita bisa lihat adalah device-nya.
tahun, ASD sekundum sekitar 14 sampai 15 mm. Untuk operator adalah Dr. Ahmad Muni, asistennya Dr. Putri dan Dr. Mamet. Kemudian skrapnya adalah Ricky dan anestesinya adalah Dr. Adi. Terima kasih, prosedur akan dimulai. Insyaallah dalam waktu.
Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. To the respectable head of Pediatric and Child Health Department of Hasan Sadikin General Hospital, Padjadjaran University, Dr. Susi Susana, Pediatric Consultant, the Honorable Dr. Đỗ Nguyên Tín from the Cardiology Department of Children's Hospital 1, University of Medicine, Ho Chi Minh City, Vietnam, the Honorable Dr. Nakisam Kemot from the Pediatric and Congenital Heart Center, Institut Jantung Negara, Kuala Lumpur, Malaysia, the Honorable Dr. SINH, Pediatric Consultant in Cardiology of Hasan Sadikin General Hospital, Bandung, the Honorable Dr. Rahmat Budi, Pediatric Consultant in Cardiology of Hasan Sadikin General Hospital, Bandung, and all the participants that have gathered here today. Let me introduce myself. I, Indonesia, will be the master of ceremony for today. Welcome to our guest lecture and interactive live cases, current treatment in critical congenital heart disease. We would like to thank everyone here for making time to attend this remarkable event. Ladies and gentlemen, on this occasion, allow me to introduce you to today's agenda. First is welcoming speech, followed by guest lecture and interactive live cases. Our first agenda will be a welcoming speech. Allow me to invite Dr. Susi Susana, Pediatric Consultant, as the head of Child and Pediatric Department of Hasan Sadikin General Hospital, Padjadjaran University, to deliver her welcoming remarks. Please welcome Dr. Susi Susana.
Mengintervensi keputusan-keputusan yang bisa mengganggu proses hukum. Pemikirannya memastikan bahwa
Halo, Dr. Sri Endah. Halo,
Morning.
Dr. Sri Endah.
Good morning.
Morning,
Good morning.
Dr. Susi.
Can you hear my voice?
Okay, I can hear your voice. You can
Very nice.
start your opening speech from pediatric department. You, Dr. Susi.
Halo, Dr. Sri Endah.
Halo, Dr. Susi.
Bisa dengar suara saya?
Yes, we can hear your voice clearly.
Okay. Sorry for
I'm sorry, Dr. Susi Susana. We're waiting for your welcoming speech.
Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning and best wishes to us all. Dr. Endah, can you hear my voice?
Yes, Dr. Susi.
Okay, I am in Ekman. I think the connection is not quite good. Yeah. Our distinguished guest, Dr. Đỗ Nguyên Tín, our distinguished guest, Dr. Marhisham Chekmud, and we are proud of the pediatric cardiology team of Child Health Department of Hasan Sadikin Hospital, Faculty of Medicine of Universitas Padjadjaran, the professors and the staff of the Child Health Department, our college students, and all of the participants. I also maybe see here our teachers, Dr. Profesor Sudikdo Satro Asmoro. Selamat pagi, Prof. Terima kasih sudah bergabung dan juga dengan yang lainnya.
Suaranya kurang keras ya.
Kurang keras ya, Prof. Ya. Apakah sudah keras sekarang?
Iya, tapi naik turun atau ya silakan.
Ya, terima kasih. First of all, again, on behalf of Child Health Department of Hasan Sadikin Hospital, Faculty of Medicine, Universitas Padjadjaran, I say welcome to Dr. Đỗ Nguyên Tín from Department of Cardiology Children's Hospital, University of Medicine, Ho Chi Minh City, Vietnam, and Dr. Marhisham Chekmud from Pediatric and Congenital Heart Center Institut Jantung Negara, Kuala Lumpur, Malaysia. It is great honor for us, Dr. Dr. Đỗ Nguyên Tín and Dr. Marhisham Chepmood share the time in child health. Hopefully, Dr. Đỗ Nguyên Tín and Dr. Marhisham Chepmood always given help in carrying out the duties. I think this is the first time I met you. And then thanks to Dr. Sri Endah, Dr. Ahmad Budi, and Dr. Putri Arayani from Cardiology Division in our department for your great effort to make the seminar, this seminar can be held. We inform that during COVID-19 pandemic, online seminar is one of the agenda of Child Health Department of Faculty of Medicine, Universitas Padjadjaran, Hasan Sadikin Hospital. It delivers the topics from all divisions. Our department has 13 divisions. One of them is Cardiology Division. In line with Hasan Sadikin Hospital and Medical Faculty Universitas Padjadjaran agenda to broaden the capacity of patient services, education processes, and also research with international collaboration, of course, Child Health Department will support this program. Ladies and gentlemen, to base our knowledge, congenital heart disease is a term that refers to a group of serious heart defects that are present from birth. These abnormalities result from problems with the formations of one or more parts of the heart during the early stages of embryonic development, and that can be classified as critical and non-critical. Considering many infants born with critical congenital heart disease in our country, and critical congenital heart disease is recognized as one of the conditions who contribute infant mortality rate in Indonesia, as Indonesia Health Ministry stated. So recognizing congenital heart disease earlier and intervening critical congenital heart disease and as soon as possible can save our children and programmatically decreasing our infant mortality rate. In this seminar, with the big topic current treatment in critical congenital heart disease, the speakers will share their knowledge, expertise, and their deep experiences regarding this disease. Dr. Đỗ Nguyên Tín will talk about the role of duct stenting in critical CHD, while Dr. Marhisham Chepmood about RVOT stenting versus duct stenting, which one is better. And then the session will be completed with interactive live case and question-answer session guided by Dr. Ahmad Budi, one of our experts of intervention in pediatric cardiology. We do realize that these activities are very useful for all of us, not only for pediatric cardiologists, but also for general pediatrician and also general. We are expecting that whatever idea we acquire from this seminar will enhance our knowledge and skills for the future. We have to constantly seek to innovate in our respective disciplines. We have to steadily implement the continuous improvement principle in all lines. Finally, we have to elevate our capabilities for the sake of the state and national well-being. Furthermore, we hope the collaboration not only in lecture, but also for other affairs, such as continuing patient services, education, and research collaborations. For all the participants, thank you for your attendance. I believe this seminar can increase our understanding about critical congenital heart disease in children. Ladies and gentlemen, at last, on behalf of Child Health Department of Padjadjaran University, Hasan Sadikin General Hospital, we would like to thank the seminar committee for preparing this event. And also, I deliver best regard for our Dean and of Medical Faculty of Hasan Sadikin Hospital. We are in a meeting with our rector, University Padjadjaran, as also the best regard for Hasan Sadikin Hospital Director. Thank you. Enjoy the seminar. Waalaikumsalam warahmatullahi wabarakatuh.
Wassalamualaikum warahmatullahi wabarakatuh. Thank you very much, Dr. Susi, for your delightful speech. Ladies and gentlemen, now we will proceed to the guest lecture and interactive live demo. This lecture will be delivered by Dr. Đỗ Nguyên Tín, Dr. Mahisan Chemot, and Dr. Rahmat Budi. This lecture will also be moderated by Dr. Sienda. Please welcome Dr. Sienda.
Assalamualaikum warahmatullahi wabarakatuh. Dear Professor, Doctor, students, and trainees. In this section, we have two parts. The first part is guest lecture, and the second part is interactive live debate. So first, our guest lecture, Dr. Đỗ Nguyên Tín. Morning, Dr. Tín. Nice to meet you again. After maybe 3 years, we didn't meet cause pandemic. Dr. Đỗ Nguyên Tín, he is our teacher. He is a very expert in pediatric cardiology, especially for intervention cardiology. Dr. Đỗ Nguyên Tín from Department of Cardiology, Children's Hospital 1, University, Medicine, Ho Chi Minh City, Vietnam. Dr. Tín will...
Good morning, everybody. First of all, I would like to thank the organizer for inviting me to join the meeting. And really, I miss all of you a lot due to the COVID time. I could not travel to Hasan Sadikin Hospital and meet all of you in Indonesian college. And today I would like to share my experience in the critical congenital heart disease intervention. Dr. Rahmat Budi would like to ask me to give the overview, not only focus on the BDA stenting, but also for the other intervention for critical congenital heart disease. He told me because of the not only the interventional cardiologist, but also the pediatric cardiologist and other pediatricians in Indonesia joined the meeting. And so I would like to start my talk is a transcatheter intervention for critical congenital heart disease. First, we know the intervention for the critical congenital heart disease just in the balloon cephalostomy in the 1990s. And since then, aortic and vulnerable blastomy performed in this age for the critical heart disease. And after that, transcatheter intervention for critical are performed in many centers on the world. But the problem is many difference from the Western and Eastern because of the morphology of the disease, also the technical issue also. And from center to centers also very different from each centers. And critical interventions, it include the critical complication. When we try to do the critical intervention, we should face and we should dealing with the critical complication. You know, the septostomy with the balloon, Ruskin's balloon is some. I think most of the center now you can do, but some case more complicated. I mean, it's interrupted IVC, and in some cases the occlusion, total occlusion of the IVC. We should go from the SVC, and some techniques should be modified for septostomy. And in some cases, the atrial septum become very thick and very difficult for balloon septostomy. We should use the stent for stenting the BFO and open the BFO for the replace for the septostomy. It's more risky for the stent embolize, and so we need to be trained, and we need to practice some more for how to prevent the stent embolize. And next, now we start doing PDA stenting in many centers, but we should know interventional options and the risk consideration when we do the PDA stenting. We start with a very simple case. I mean, simple case means the PDA is very straight, and also arising from the descending aorta. And it's very easy for everybody to cross the PDA and put the stent. And I think when we start doing the PDA stenting, we should start with a simple case like this. And next we start with a more complicated case with vertical PDA. You can see the PDA arising from the transverse aortic arch. And so we need some curve. And with the curve, we need some use modify catheter such as the cut detail with different curves for approach the PDA. In some cases, it's more difficult with the bifurcation or trifurcation stenosis. You can see the PDA arising from the innominate artery, and when it arrives to the pulmonary artery, you can see RBA, LBA, and PDA also stenosis, and so-called the trifurcation stenotic. It's a more complicated case. In some cases, you see the not the stenosis in the ostium of the RBA or LBA. It's a long segment stenosis. And if we put any stent to RBA and LBA, we will make the new onset or may make the worsening of the LBA-RBA stenosis. And here you can see the more difficult case with the hypoplastic LBA. It means the very related RBA, but LBA very hypoplastic. And in some cases, the PDA looks very short. And if we put the one stent through the LBA or RBA, this case, a stent through the RBA, and you can see the LBA become more stenotic like this, and very easy to be of total occlusion. And this case, the stent is too long because the PDA is very short. We don't have a very short stent. Most of coronary stent is 10 mm. If the PDA a little bit shorter, 10, maybe we have some problem with the chilling the LBA and RBA due to the long PDA, a long stent. And in some cases, how to deal with that bifurcation stenosis. And you see the case with the trifurcation stenosis like this. First, I put the one stent through the one pulmonary artery. I mean, this case, I put the stent through the PDA to the RBA. And you see the LBA become more stenotic. And what should we do? We put one more stent for cover totally of the PDA. And we use a balloon for dilatation of the RBA. You can see LBA, sorry, and you can see after ballooning, you can see the LBA and RBA are open well, and the patient can wait for the next surgical repair. And this case is more complicated. The PDA almost be closed, and LBA and RBA also very stenotic. You can see when I put the stent through the PDA to the RBA, LBA almost disappear. And but we should put the stent because the patient is so cyanotic. And after the first stent with from the PDA to RBA, we try to use a micro catheter and guide wire to cross the LBA again. And I mean, the first stent may can cause the total occlusion or maybe worsening the LVA stenotic. And with the balloon, you can see we can open the LVA, and after the ballooning, you can see the LVA still stenotic, and we should put the other stent. And so stent in the RVA and stent in the LVA and PDA also. And so it means for the ostium stenotic, we can use the balloon. But a long segment stenotic of the branch of PA, we can use the stent. And other complicated PDA stent morphology for stenting is the curve and the long PDA. And how can we put the stent in any center? They do the CT scan, or you can do the many weapons for measure the length of the PDA. But it's a total and long segment. It's not easy to measure exactly the length. And so for technical issue, we don't mind too much about the length. What we do, we put two stents. The first stent go to the pulmonary artery. You can see the first stent just open the pulmonary artery end of the PDA. And the remain between the first stent to aorta, we can put a second stent accordingly the length of the remain tissue, remain PDA. And so for me, two stent is the more easier and much more simple than the one stent, long stent. And other complicated PDA for PDA stenting is mean bilateral PDA. The bilateral PDA, for technical issue, we can cross the guide wire and we can put two stents in the two PDA. But the problem is the size of the stent for single lung. We cannot put too big stent because it will be overshunt for each lung. And it's very not easy to make the decision how big is the stent for the bilateral PDA. In this case, you see, we try to put two stents in the bilateral PDA. But my experience, the stent is not bigger than 4. And so we should pay attention for the overshunt after putting two stents in for two lungs. And one big issue is the thrombosis. And you can see most of patients is with the PDA with a large ampulla, but very small or tiny opening exists in the pulmonary artery. And so when we put the stent, you can see the some space between the stent and the PDA. And it means the stent cannot touch the PDA wall, and it's a high risk for thrombosis over there. And if the patient is some problem with the hypothermia or hypotension, and the high risk for the thrombosis happen and can close the PDA. And so if we put a bigger stent for totally approach to the ampulla, maybe overshunt. And so we should deal with a small stent with high risk thrombosis and embolize, and big stent for overshunt. And what should we do? We try to put the first stent with a reasonable size for the patient body weight. But the first stent in the pulmonary end. The second stent, maybe I can use a bigger stent to cover most of the ampulla, and we can reduce the risk of thrombosis, and we can keep the reasonable flow for the pulmonary artery, and also for preventing the stent embolize. And so the how to reduce, I think two stents. The first stent is smaller in pulmonary end and bigger in the ampulla. In some cases, a very difficult case, PDA spartum. You can see the PDA looks very beautiful. We can put a guide wire and do put the stent easily. But after boosting the guide wire, you can see the PDA almost be spartum, and you can see the PDA is almost disappear. And it's not easy for putting the balloon of the stent again through the spartum like this, and high risk patient. Of course, patient become the very worsening cyanotic, and it's a high risk for mortality. And this case, one case, most complicated case for me is you see the PDA almost be closed. I try to put a micro catheter and do angiography. You see it's very beautiful, and try to cross the guide wire, but after try many times to see the PDA is dissection, and dissection is almost disappear the PDA, and of course patient becomes very worsening, and we should deal with them. We cannot send the patient to the surgery SI. We cannot use the BG1 again to open the PDA for the dissection PDA, and of course it's not easy for crossing the dissection. And as one other problem we should face is the stent migration. You can see when we inflate the balloon, the stent tends to slip to the bigger part of the pulmonary artery. And when it slips to distal, you can see the LVA become very stenotic and high risk. And of course, we should put other stent to cover totally the PDA. But you can see after the two stents connected like this, the LVA become more worsening. And when the two stents cover the LVA, it's not easy for guidewire crossing and balloon crossing again. And this is a technique for using the two stents connected together. You can see the first stent when I put the first stent to the pulmonary artery, and so I keep the balloon and I inflate the balloon, and you can see with a very curve like this, when the balloon inflated, and I deflate the balloon and I cross the guiding catheter. And with the technique inflate and deflate balloon and crossing the guiding catheter, you can see the guiding catheter can go inside the first stent easily. And with the guiding inside the first stent, you can put the second stent connected together with the first stent. And here also any technique in the curve in the pulmonary artery, and so you can see the guiding catheter can go easily through the first stent for the second stent putting. The second section, I think Dr. Mahesham will mention more about the RVUT, and I just mentioned some. RVUT stenting in follow just indication for the very young, very small baby, for too young to surgical repair, and hypoplastic pulmonary artery. And some cases with the ABSD with follow, we need to do the RVUT, not the PDA stenting, or some MAPCA, and of course the result better. You can see this case very small LPA, RBA, also MBA. We cannot do BD shunt or also complete repair, surgical repair, and so we need to put a stent not only for hypoxia spell, but also for development of the LBA and RBA for the surgical repair later. And here you can see the LBA and RBA looks very hypoplastic, and of course when you see after putting the stent, RBA and LBA have changed to develop later. And the problem is how to put the stent with the preserve the pulmonary valve. Some cases the pulmonary valve looks very beautiful. We try to put the stent underneath the valve and we can preserve the valve. But some cases not easy like this. The landing zone is too short, and so the valve also hypoplastic. We try, but we cannot. If we put the very short or very low stent, maybe the risk for the stent embolization. And you can see for the too short landing zone like this, the RVOT to the pulmonary artery valves are very short. And we cannot keep the reserve the valve, and so we put the stent over the valve. And I think it's a reasonable option for the patient. And some cases we try to put underneath the valve, but you see after 1 month the patient becomes cyanotic. You can see still stenosis about the valve and inside the stent. And we should send the patient back to the cath lab to put the other stent, and you can see two stent, stent, also very good result. And in this case, I would like to share you the risk of the RVUT stenting. I try to put the stent underneath the valve to preserve the valve, but after I inflate the balloon, I deflate the balloon and pull back the balloon, you see the stent slip into the RV. And also it's a stent embolized to the RV. And I try to put the second stent connect to the first stent and also the open the RBUT. But you can see the second stent, when second stent open, it looks okay. But after the second stent, you see the second stent can fix RBUT well. But the two stents still separate together. And so I try to put the third stent to connect two stents again. And so totally 3 stents for the RBUT stenting. Luckily, the 3 stents not touch or interfere any problem or cause any problem for tricuspid valve. But it's a high risk for stent emboli if we try to put the stent underneath the valve for preserving the valve. And also this case, my colleague, she did very beautiful. Everything looks okay on the lateral view. You see the stent looks very good. But in the IL view, you see the stent, the tip of the stent touching, cutting the RBUT. And this patient developed the epicardial effusion after several hours. Luckily, the patient is okay, but pay attention with the angulation between the RBUT and MBA if we put the stent there. For BA-IVS, also the many problems. You see BA-IVS looks very beautiful for morphology for the NGUY crossing, and also we can perforate the valve. But when you see we open the valve crossing with the NGUY, and you can see after putting the ballooning, and we think for the small RV, we should put the PDA stenting also. And so for BA-IVS, many options. First one, we perforate the valve and the PDA stenting, and you can see which one is better. And in this case, you can see after perforate the valve looks very beautiful. And but RV is still small, and we use balloon and should put the PDA stenting later. But with the two procedure, which one is the first? PDA stenting first, or the perforate the valve first? And depending on the patient, if patient is severe cyanosis, we try to put the PDA stenting to rescue the patient first, to increase the saturation first. Also, the BA-IVS, the PDA looks morphology is very simple for PDA stenting. And when the patient becomes stable, we can perforate the valve later. And some cases, you see the risk consideration is looks very beautiful. We can cross a microcatheter to the pulmonary valve or perforation. But some cases you see it looks very beautiful, but in the lateral view, you see the catheter is goes a different way, and it's a high risk for the complication. You can see some contrast outside the heart, and here also, and so we see can see the catheter. It looks okay, but it's not really okay, and high risk for the perforate the RBUT and epicardial effusion. And for the pulmonary vein stenosis, also is a critical intervention for the small baby. You see, most of cases not easy for intervention the pulmonary vein stenosis, but the patient is very severe with pulmonary hypertension. You see, the pulmonary vein is almost be close with the guiding catheter crossing, but it looks okay after we put the stent, pulmonary vein stent there. In some cases, not easy. In this case, a very long segment. We try to put the stent, but the stent go inside the somewhere, and you see still the waves there. And it's what happened because the stent too deep inside the pulmonary vein, and so it went to the one branch of the pulmonary vein, and so it's a not good result. And so when we put the stent, it's different from the venous and the arterial angiography. The venous is the contrast going back, and you cannot see more clearly as a distal. And so something wrong with the distal part of the stent like this. In this case, a very complicated case of multiple pulmonary vein stenotic. You see the lower pulmonary vein stenosis, and we put the stent. Looks very beautiful. And second, and after the first stent, we see the other pulmonary vein stenotic cell. We put 2 stents like this, and it's very high risk for the stent embolization. And next is the aortic valve stenotic. Aortic valve stenotic is still a very complicated and a very difficult for making decision. The surgery or ballooning and the surgery in neonatal barrier is a difficult technique for the patient. It's ICU and poor outcome. The balloon also is a reasonable option. You can see this case very severe, and of course we can use the balloon dilatation. But some case more difficult. You can see the LVOT also stenotic, and the valve not only about the LVOT is stenotic. And but if we can just use the balloon for the, I think the reasonable result is better than the best result. And so we just use a balloon, very small balloon, to open the valve and accept the reasonable result. I think it's better. And other critical intervention for small baby is the coarctation in the neonatal. And also the question is surgery, a balloon or stenting, which one is better? The balloon in the severe patient, I prefer to use a balloon for that. Such as a patient with a compromised hemodynamics problem and renal failure and acidosis, the stent approach is also the problem, the second option. And now we have many kind of stent, so-called the closed stent or open cell stent, such as a formula stent. The stent can be further dilatation for future, and also is a good option for the patient. Many years ago, we tried to use a balloon for the critical coarctation. We approach from the subclavian or the axillary artery. You can see with the balloon looks very beautiful result. We can get a reasonable result for this patient. But now we changed our practice. We prefer to use the stent. You can see the stent is easy, very easy for open the coarctation. But we one main problem, we don't try to further dilatation with the distal part of stent. We keep some space between the stent and the descending aorta. It's very easy for the surgical repair later. They have some tissue to connect and to repair the coarctation. If we try to open the distal part of the stent, maybe we can make it more difficult for the surgical repair later. In this case also, you can see the patient with severe coarctation and BDA, very small BDA. And after stenting, you see, you put a short stent and keep some space between the descending aorta and the stent. And so for the hypoplastic, for interrupted aortic arch, also we can put the stent from the pulmonary artery. But in this case of the stent, we need the bigger stent. Maybe we need at least 6 or 7 mm stent for safe and with enough flow for the systemic flow. The last one we should do is TCA with the IBS. The patient came our hospital is very late phase. I think not only Vietnam, but also in Indonesia and other developing countries also have some patient like this with a very poor LV function. And of course, it's not easy for surgical repair. And so we did, we tried to do the so-called the LV training. We can training LV with the volume training. And so we put the BDA setting, and we can training with pressure. And so we use PI bending. In this case, we see the TGA, the pulmonary artery is posterior and from the LV. And you see the stent can put to create the open the BDA for volume training. And so my conclusion is the trunk catheter for critical congenital heart disease still is a difficult procedure and with a high risk procedure. The procedure approach depending on the facility of each center. Facilities mean the medical staff, the equipment, and also the technical issue for the operator. And the problem is we setting the practical and physical program is very necessary for each center. We can learn from other center and we we should ask our center should do like this. And so based on the each center, what we have facilitate, we can set up the program. And thank you very much for listening. Thank you very much, and congratulations for meeting in Hasan Sadikin Hospital.
Thank you, Dr. Tín. So we will go to the next speaker, Dr. Mahisam Semut from Pediatric and Congenital Health Center Institute Jantung-Negara, Kuala Lumpur, Malaysia. If a participant have a question, you can chat in chat room, and Dr. Tín and Dr. Mahisam will answer maybe with in online or with text, the answer in text instead. Okay, Dr. Mahisam, it's time for you.
All right. Do you all see my slides clearly and hear my voice clearly?
Very doc.
You can?
Yes, yes. Okay.
Okay. So, good morning. Assalamualaikum, everyone. So this is my task for today. It's always difficult to talk after teen. It's either make your life more difficult or make your life even easier. So I think in this situation, teen has made my life much better. It's easier for me to talk on these two procedures. Sorry, I have to stop in between because I have this chronic cough. Okay, by the way, so I would like to thank Dr. Rahmat Budi and the team for the invitations to be part of this symposium. And selamat sore semuanya. So my talk today is on PDA stenting and RVUT stenting. Which one is better? All right. So why not we go through to these two procedures? So I will start with a ductal stenting procedure, and Dr. Tín has described the gist of this ductal stenting procedure. So when we talk about this duct-dependent lesion, we cannot run away from these two types of pulmonary atheresias. So one with a straight PDA, the straight cause, and the PDA stenting usually very straightforward in this case, as like we see in patient with pulmonary atresia intact ventricular septum, and the procedure is not so much complicated. The second group is basically the indication 2 or the class 3 indication under AHA guidelines. So this is basically the stent that function as a sole source of pulmonary blood flow into the pulmonary circulations. We can see those with two ventricle of pulmonary atresia, or even very severe TOF pulmonary stenosis, or those with TGA VSD pulmonary atresia, or CCTGA VSD pulmonary atresia. We can also do a PDA stenting in patient with a single ventricle, example like isomeric heart unbalanced AVSD with pulmonary atresia, or frequently what we see is the ILD with a pulmonary atresia. However, the PDA in this group of patients might not be stent friendly. The morphology is very complex, and usually it inserts into proximal left pulmonary artery and causing pulmonary artery coarctations. So the issue with this group of patients, basically the technical, vascular access, complications, and also the fate of this stenosis of pulmonary artery. So let's go with a pulmonary TOF pulmonary atresia. We can see the upper right panel. This is the most of the time TOF with pulmonary atresia comes with PDA that coming from underside of aortic arch and inserts into the proximal part of the LPA. So this area will cause a pulmonary artery stenosis, branch pulmonary artery stenosis. And we can also see the PDA from the 13th slide, the PDA that arises from the subclavian artery and inserts into the proximal left pulmonary artery. We can also see a 12 temperature with bilateral PDA. So we might need to bear with the size of the stent that we are going to put in for this group of patients. And of course, we do have a patient with MAPCAS with no PDA. So as mentioned, the morphology of PDA in this group of patients may cause issues with vascular access, technical challenges, and also complications. So we also have to query, will the ductal stenting procedure causing worsening or acceleration of the stenosis of the branch of pulmonary artery? So this also may impact on the surgical repair. So our surgeon may have issues in terms of reconstruction of a pulmonary artery during the surgical repair. So example like a patient with PDA, right aortic arch with proximal pulmonary artery stenosis, or in patient with left aortic arch with proximal left pulmonary artery stenosis, we have to think of how to
recording stopped.
How to deliver the stent, and also how to place the stent into the right side of pulmonary artery, which causing less flow into the left pulmonary artery, or the stent is placed into the left pulmonary artery, which causing less blood flow or interrupted blood flow into the right pulmonary artery. So this is something
recording
that
in progress.
we decide, and before we embark on PDA stenting program or procedures. So the ductal stenting that cause pulmonary artery stenosis is basically based on the scanty evidence, and we have very limited data that how's the fate of this pulmonary artery in the future before patients undergoing any surgical repair. So we need to study, and also we need to learn the better technique, especially the route and the vascular access for the procedure itself. And also our surgical colleague has to also improve their ability. And I believe nowadays, I think the surgeon is able to repair this pulmonary artery stenosis, either this is native pulmonary artery stenosis or stent-related pulmonary artery stenosis. All right, so this is just example of a few technique of PDA stenting. Is either transvenous, trans-VSD for TOF pulmonary atresia, and those with through the subclavian and axillary artery, either right or left axillary artery. And we also perform PDA stenting through transcarotid artery. So just a simple example to highlight one of the patients who had a PDA stent through hybrid procedure in our regular cath lab, where our surgeons basically open up doing some cut down, and also identify the carotid artery. In this case, it's a right carotid artery, and provide us the access for us to basically perform the PDA stenting. And this, in this case, I think the PDA stents is able to be delivered directly into the PDA, and stent is implanted directly into the left pulmonary artery in this case. So this is basically a well-known access for PDA stenting, and I think Justino and team has published this in 2016. So the axillary access probably the more popular way of performing PDA stenting, which usually we cannulate, identify the axillary artery and put in the sheath. So, and from this sheath, I think the stent should be able to be delivered once we have a good wire position. So example, in these patients where the right axillary artery was cannulated and the JR for French catheter into the for French sheath was placed in the directly into the PDA, and the two coronary guide wire was placed into the left pulmonary artery initially, but I think because of we see severe proximal right pulmonary artery, and the decision was basically to change the stent position more into the right side. So the wire now is basically part in the left, in the right pulmonary artery. And when the stent delivered, you can see, I think, the proximal left pulmonary artery stenosis, and this left pulmonary artery stenosis was basically intervened later on, and the result was very promising, where the both pulmonary artery has very good size before surgical repair. So when we study the fate of this jail pulmonary artery, is the impact after PDA stenting, we notice that the difference is not significant. Basically, those with a PDA stent who had a jail pulmonary artery has significant growth of the affected site. This is comparable with those who underwent, patients who underwent modified BT shunt. And basically for those who cannot do PDA stenting, which tortures PDA, or those patients who had some conduit repair. Example, in our cohort of patients, this is the patient that I mentioned just now, who had a proximal LPA stenosis after stenting. But after 9 months after stenting, you can see that the growth of the left pulmonary artery is basically not jeopardized because of the stent into the right pulmonary artery. So the flow is actually just enough from the strap of the stent into the left pulmonary artery. So basically, this is from our own cohort. You can see, I think, only 3 patients out of these 34 patients who had poor pulmonary artery growth, and most of patients has satisfactory pulmonary artery growth before the surgical repair. And all these 3 patients, one had a BT shunt, another 2 patients has had 2 PDA restenting into the affected site. Okay, so this is an example of that one patient who had a PDA stenting, and after a year after stenting, we can see proximal LPA stenosis, which are clearly seen on the pulmonary vein wedge angiogram. And this patient was stented, and good growth into the left pulmonary artery. So the second part of the presentation is basically to compare with the RVOT stenting. So basically, these 2 procedures is uncomparable. Basically, in terms of the indication, in those with a procedure that undergoing PDA stenting, is very broad indication. You can do it in those with a single ventricle, those with a 2 ventricle physiology. For RVOT stenting, is very limited indications. Is widely accepted dilation for patient with a symptomatic fellow who had a severely sinus, and this is considered as an alternative to BT shunt. As Dr. Tin mentioned, I think those with a very small pulmonary artery to allow the growth of the pulmonary artery, and those with a comorbidity that probably not suitable for the early repair. In our institution, we try to do a tough repair as soon as possible, provided the anatomy is a very very good, and branch pulmonary artery is acceptable. So the RVOT stenting is basically even though this is a limited indication, this is widely accepted as a tough initial palliation. So basically, we know that the neonatal TOF repair is very uncertain outcome, and the indication for RVUT stenting is basically to stabilize the patient before undergoing any surgical repair. Because we know that patients with hyperspastic spell, they tend to be very sick, require multiple inotropes and ventilated. And we know that with RVUT stenting, the growth into the pulmonary, the flow into the pulmonary artery is more homogeneous compared to PDA stenting or BT shunt. And of course, our surgeon has a very virgin chest for them before the procedure, the surgical repair. But of course, we need to deal with the stent during the surgery. So the removing of the stent might be a bit an issue, because if you do the surgery very late, the issue to remove the stent from the RVUT is probably a bit difficult. But if you do the stent the surgery much earlier, you should be able to remove the stent completely, or at least a partial removal of the stent at the RVUT position. And the issue mentioned by Dr. Tín, either to preserve the valve or to cross the annulus during the stenting, probably something that we shall discuss. And also the questions related to the valve annulus size is probably another issue that we need to discuss a bit later. So these two papers basically highlight important of doing RVUT stenting in patients with severe failure tetralogy, and also how the surgeons deal with the stent during the surgery. So in failure tetralogy, we know that there is a very diverse morphology. You can have a patient with very good anatomy. Our surgeon used to call this as their dessert, right? Patients may have a very decent pulmonary valve annulus, like in this patient, and good pulmonary artery anatomy, and patients with a single outlet ventricular septal defect. So in this group of patients, early TOF repair is probably recommended. So the second group is basically those with present very early in life, and palliation is probably something that we need to consider. So this patient presented with a hypersynovic spell, very tight RVOT, small pulmonary valve annulus, and also small pulmonary arteries. And of course, the other type is those with TOF pulmonary atresia type, and with no doubt this group of patients require the procedure like PDA stenting or PT shunt. Right? So RVUT stenting as compared to PDA stenting is more straightforward. And when we have a case, especially with small pulmonary valve annulus, the infundibulum region is very well defined on the angiogram. And we know that we have two areas of anchoring this the stent at the valvular level and also infundibular level. And the stent is well gripped by the valve tissue and the infundibular tissue. Example, like this patient has very tight infundibulum, very small flow into the pulmonary artery. Once we cross with the guide wire with the guiding JR in situ, and after the stent implantation, you can see the nice flow into both branch pulmonary artery. So this is another case of a patient with TOF pulmonary atresia, TOF with MACA, and the MACA is basically supply most of the right lung, only small right pulmonary artery seen on the angiogram. So this patient has a beautiful MACA and basically covering almost 75% of the right lung. So what we did is basically cross the pulmonary valve, infundibulum and pulmonary valve, and also stented the RVOT. And after a few months, then we can see the nice flow into the right pulmonary artery. Is basically the native pulmonary artery of the right side, supply at least 60% of the blood flow into the right lung. So this patient then had conduit and also unifocalization of this MAPCA. And this is basically after the surgical repair. Okay, so this is the surgery, the result of surgery after RVOT stenting. Basically, our surgeon has no issue in terms of removing the stent from the RVOT stenting. And I think this paper was published when I was in the center. This is Birmingham Children's Hospital, and we can see basically the removal of stent is probably not a problem. The surgeon will remove completely, or they will keep the posterior part of the stent and perform the transannular patch, and is comparable with other TOF surgery, either patient who had a PDA stenting or patient who had a PT shunt before as the palliation. All right. So this is another patient with TOF hypersynaptic spell who had infundibulum that not so clearly seen on the angiogram, but the annulus is probably quite decent. So in this type of cases, we should basically think of a suitability of RVOT stenting, because if there is no tight infundibulum, anchoring the stent at the RVOT is probably something not safe. And in this group of patients, if patient had PDA, probably PDA stent is a better option, or you can do just balloon RVOT, or at least give a time of at least 3 months before the surgeons can perform the corrective surgery, especially when the patient has a good pulmonary artery anatomy. So this is a patient who is 1 month old, who had severe cyanosis and presented with a severe cyanosis and mild tachypnea. Echocardiogram showed very small pulmonary valve annulus and very tight infundibulum from the echo. When we did PDA stent, RVOT stent, we noticed that the initial deployment of the stent just beneath the pulmonary valve, and once we inflated, it's basically moved downwards into the RVOT, and also later on move even further to the inlet portion of this RV. So RVOT stenting, even though it's straightforward procedure, we have to consider good anatomy, especially to anchor the stent at the RVOT region and also pulmonary valve. And this embolized stent is basically, in this case, the patient had a PDA stent via right axillary artery, and this patient, the previous patient had surgery at 6 months, and the stent was removed basically during the surgery. So this is another patient who had 12 hypersynaptic spell with imperforate anus on colostomy. So surgery is probably a bit risky in this group of patient. Then we perform RVOT stent, and the stent migrated into the RV body and was removed. Later on was removed by snare catheter, and also we put in another stent which was a bit stable, and this patient had TOF surgery 6 months later after revised colostomy. All right. So how do we avoid the stent migration? The migration can be either forward into the pulmonary artery, which will definitely be salvaged by our surgeon during the surgery, or can be migrated downward into the RVOT or RV body. So the stent has basically to be well anchored, as I mentioned, by the pulmonary valve, a small pulmonary valve annulus. And more importantly, the infundibulum stenosis has to be well defined in the angiogram before we deploy the stent, and the stent is dilated, is inflated in the RVOT. So as a conclusion, PDA stent is very wide indication, right? The class 2 indications is basically for those who require the sole source of pulmonary blood flow into the pulmonary circulation. And the second option is basically the patient who had multiple anatomy, those with two ventricles of physiology, or patients with single ventricle physiology who had a pulmonary atresia, and PDA stent is considered as sole source of pulmonary blood flow. So the indications for PDA stenting is widely acceptable. However, we have to be concerned on the jailing of left pulmonary artery, causing poor growth of the left pulmonary artery. And also discuss with our surgical colleague, basically the difficulty in the surgical repair might probably impact on the surgical repair outcome in the future. And nowadays, I think we have very reasonable data to say that the PDA stenting in this group of patients, even though with branch pulmonary stenosis, is a feasible and safe procedure. For RVOT stenting, it's a very limited indications, but of course, it's a very good alternative for as compared to BT shunt for TOF with a cyanotic spell. The TOF is not only the straightforward TOF; it can also be the TOF variant like URV TOF or those with AVSD TOF. Of course, the technicality is a bit more straightforward compared to PDA stenting. And we have to basically define the infundibulum stenosis on the angiogram before a stent placement. And for those who had a small pulmonary valve annulus, is probably not the issue for us to implant the stent, as we need to basically do a transannular patch during surgery. Of course, those with a good pulmonary valve annulus, you may consider PDA stent if the PDA is still there, or BT shunt is probably preferable to basically preserve the valve and also the risk of stent migration if you cannot see a good infundibulum for you to anchor the stent at the RVOT position. And for those who perform RVOT stenting, please follow up the patients closely, and the surgical repair should take place at least within 6 to 9 months after the procedure. So with that, I thank you all.
Thank you, Dr. Sam. I think it's a nice presentation. For all participants, if you have a question, please text in chat box, and then that you write for the question is for Dr. Tin or Dr. Mahisan. So now we go to the next section, is interactive KịCH. Dr. Supriya or Dr. Budi, are you ready?
Good morning, Dr. Mahisan and Dr. Tin. Now start with the first case. Maybe Dr. Ina, can you show the PowerPoint? Slide, please. Okay, this is our first case. 6 months old male with cyanosis and poor weight gain. He came with a very late presentation. Body weight only 5 kg, and the oxygen saturation only 69%. And the working diagnosis is pulmonary atresia, complete atrioventricular septal defect with the PDA. Slide, please. Okay, this is the chest X-ray. We see no decreased pulmonary vascular marking. Okay, slide. It's only the photo, and this is the echo. This is the echo of this patient. Slide, please. We see the single atrium and single ventricle, common AV valve. There is no flow from RV to the pulmonary artery. Another echo, please. Okay, this is no flow from ventricle to pulmonary artery. And the echo beside this is the PDA. The suppressed therapy show the PDA from the arcus. So this is the vertical duct. Now Dr. Rahmat Budi will perform the stenting PDA in this case with the access from a carotid artery. Okay, please maybe Dr. Budi will explain a little. Kamera sini aja. Terus kamera sini.
Halo, good morning. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you very much, Dr. Dotin and Dr. Mahisam for joining today. So, first case, as Dr. Putri explained, is pulmonary atresia, CAVSD, with hypoplastic left ventricle. So, for the future, this baby will go for single ventricle palliation. So this case is actually a late presentation case. The baby just arrived to our hospital at 5 months old with desaturation, 50% in room air, and then the duct is coming from aortic arch. Is long tortuous, very big in proximal aorta, but small and stenosis at the junction of the pulmonary artery. So we plan to do duct stenting through carotid artery approach, and then I can show you the angiogram. First angio, please.
Oh, di video atau
Nah, ploro awal.
bersatu mas, peran satu.
So, saya juga bicara dalam bahasa Indonesia untuk audiens yang lain. Jadi ini adalah kasus critical congenital heart disease yang late presentasi. Jadi datangnya sudah terlambat sebetulnya. Datang ke kita pada saat beberapa minggu lalu dengan desaturasi ya. Kasusnya adalah pulmonary atresia dengan CAVSD Nah, di sini saya masuk dari carotid artery dengan GR, guiding catheter. Kita lakukan action, as you can show on the picture. You can see that the previous one, please. Previous one. The first one. Next. Yes. Yeah, that one. Yeah. Part at the junction of the pulmonary artery. You can see the right pulmonary artery and left pulmonary artery, but without main pulmonary artery. And then there is a stenosis part on the right and left pulmonary artery, but I think you can see the left stenosis is more tight compared with the right one. Next. Then we introduce the run-through coronary wire. Next. And then we plan to manage to put the stent just only on the stenosis part. Actually, we should put also the bigger one after we put the small one, but we don't have 5 mm coronary wire. So we just want to put the stent on the stenosis part. Next. Because this patient don't have main pulmonary artery, so I managed to put double wire to avoid the stent go through the distal part of pulmonary artery. Any comment, Dr. Tin, Dr. Maisam, or audience?
The question is why you choose the carotid artery for approach in this case? You can use an auxiliary or maybe I think it's safer. Femoral artery also is safer.
Yeah. Yeah, we can choose both auxiliary or carotid. But if we choose carotid, I think it's more easily to introduce the wire and also the stent. This is dia bergaung.
And second question is, do you intend to use a balloon for dilatation, the LPA before stenting, or just put a stent and see what happens and you make the decision
just
later?
Put the stent.
All right. Have you tried to cross into the left pulmonary artery?
Yeah, we cross left and right pulmonary artery, but after we introduce the stent, the right wire tend to go to the left, but it's still on the right the left pulmonary artery.
So have you stented the PDA?
Sorry?
Have you stented the PDA?
No, not yet.
Not yet. Okay. So basically,
do you have any suggestions?
Also, basically, we have many experience with a single ventricle patient because we know that the Glenn shunt will not provide the high pressure after the reconstructions of the pulmonary arteries. So if you intend to put in the stent, so the stent is basically shouldn't be too much in the pulmonary artery lumen. It has to be just nice across the stenotic area of the PDA stent. And at best possible, try to recross into the opposite side of pulmonary artery. And don't put the stent, but at least you can just balloon the strap. Make sure the flow into the opposite pulmonary artery is well maintained. With this technique, we noticed that the PA reconstruction during surgery is probably much better because our surgeon doesn't have to meddle too much with the reconstruction. And after the gland, we have to closely follow up.
Suaranya.
And Budi,
Yeah, thank you very much for your.
What's your next plan?
How long do you plan for next stage after stenting?
As long as you have good anatomy, patient is beyond 6 months, I think that's good to go.
Okay. Adatin, do you think I should ballooning the right part of pulmonary artery?
I think the left side is more severe stenotic than the right side. And your plan, what your plan? You put the first stent to just in the bifurcation, or the first stent through the BDA to the LBA or RBA. And if I have the same idea with the mysham, if and through from the BDA to the pulmonary artery, I think we try to boost the first stent through the BDA to LBA. And RBA is big enough, and we easy to use a balloon for further dilatation. If the first stent slip to the RBA, we have some problem with LBA crossing and balloon and more difficult. And I think the best way, if we can put the stent just above the bifurcation, is okay. But sometimes it's not easy. And what's your plans next?
Actually, our first plan is just to put the stent just bifurcation. So this not easy to introduce the coronary wire to the left side because it's very tight. So I think maybe the first choice is just put the stent just before the bifurcation, or the second option is to ballooning the left one, then put the stent. Well,
can we see the angiogram again?
Please show the angio. So this is after we cross the left and right side of pulmonary artery. Any comment?
I think the stenosis is very tight. It's probably place the stent only at the bifurcation might accelerate more stenosis.
Yeah.
But of course, be prepared that you may need to add on another stent.
Sorry, I can't hear you clearly.
Because this one showed a tight stenosis.
Yeah.
Right. So putting the stent only at the bifurcations, you may
before
have
the bifurcation.
Yeah.
Yeah.
You may have a trouble of accelerated stenosis of the affected side.
So I introduce the stent. As you can see, the left part or the coronary wire on the right, left pulmonary artery tend to go to the left side also. Any tips?
The stent crossing which one of the guidewire, the left side or the right side?
Left.
Oh, and of course, you see the tip of the stent is a balloon, and some parts of the balloon could not cross in the LBA. And so if you use the left guide wire for crossing the stent, you should use a balloon before and make the ostium of the LBA becomes larger and bigger. If you try to do this way, the LBA guide wire will slip to the RBA again. We cannot. I think it's a very difficult.
So if you do to balloon, what size of balloon?
I think we just don't try to use very big balloon, 2 or 2.5 mm, and very short balloon number 10 or 15 mm is okay. And I think you should retrieve put back the stent and change to the balloon and use balloon. When the balloon inflation, you try to cross the guidewire as far as possible and more distal and make it more support for the stent later.
Ya, thank you very much. Ya, yang terhormat, jadi ini kasusnya cukup sulit. Yang pertama karena dia tidak mempunyai main pulmonary artery pulmonary yang utama yang biasanya keluar dari ventricle kan, sehingga pada saat saya introduce wire itu ada satu bagian yang stenosis di bagian pulmonary artery yang kiri, sehingga kita kesulitan untuk menempatkan stent supaya pas dia di percabangan dari si arteri pulmonaris kiri dan kanan. Oleh karena itu mereka menganjurkan untuk melakukan balloning dulu di sebelah kiri, baru nanti stent selanjutnya bisa lebih, kita harapkan bisa seperti itu. Mungkin ada pertanyaan dari audiens, boleh dalam bahasa Indonesia. Kalau tidak ada, saya lanjutkan. Oke, kita tarik stand-nya. Karena ini enggak, ya. Yang ini. Bagi balon 2 mili. 2,5 boleh. 10.
Mas, 2,5 pendek mas. 10. Fluoro atau?
Enggak, fluoro aja ini biar enggak lepas ya. Mana tadi ini Den? Oh, dia cenderung gitu dia. Ada itu enggak? Oh, ada apa namanya ini? Tadi teh. Top. Fluoro lagi, fluoro.
You should remove the stent outside totally and change the guide wire later. You cannot change the guide wire with the stent inside.
Can we have the fluoroscopy during the procedure?
Pegang. Kan? Iya dia. Dia udah ke kiri dua-duanya. Saya kira kita tarik aja. Yuk. Fluoro off. So I would like to introduce again the run through coronary wire to the left side.
Tolong pasang propar di over.
Dorong dikit. Puterin. Oke, kedalaman. Fluoro off dulu. Oke, fluoro. Tarik dikit ininya, JR-nya. Belum, puterin aja. Nah, oke. Puterin. Ini puterin. Oke. Kesana. Kejauhan dikit. Injek deh.
Patient may also have some significant blood loss.
Oh, sorry.
So, yeah. Your stop cord probably not closed.
Yuk. Kejauhan. Cok. Kejauhan. Tarik dikit. Ya.
Budi, I think you should counterclockwise, not clockwise. Counterclockwise rotation. Budi, you are clockwise rotation, and so it's go to the right side.
Thank you, Dr. Tin.
Buka aja tuh. Kloro terus dipikir. Udah masuk deh. Bentar, kita sejauh mungkin. Sok. Oh, peluru lagi. So I will introduce balloon into the left pulmonary artery.
Yeah, but you should check the Y connector. Too much bleeding. Any problem with hemostatic valve, and be careful with clots.
Yuk.
How big the balloon you intend to use?
Sorry?
How big the balloon now?
Balloon 2.5.
Yeah.
10. Ada yang kunci dulu. Lebih lancar ini kan kecil balonnya. Fluoro. Inject them. Inject. Ininya GR-nya mungkin tarik dikit. Oke. Kemudian balonnya tarik dikit. Yuk. Ya. Inflate. Or off. Okay. Do you think position of balloon is enough for dilating?
Yeah, just open for the stent crossing, not too much now.
Too distal. I think
That
probably
balloon,
need to pull out to the junction.
yeah, just pull back a little bit.
Yeah.
Okay. Okay. Yuk. Ya. Mana kontrasnya? Oke.
No.
Ya, deflate.
I think you need to expose the balloon a bit more. Pull the catheter a bit to higher up.
So I will pull the catheter.
Yeah.
Little bit. Okay, fluoro. Then I will pull also the balloon just little bit.
Yeah.
Okay. Inflate. Okay.
Okay.
Okay, I will pull out the balloon and then change into the stand.
Right. Yeah.
So you are stenting to the left side, right?
He intend to put the stent above the bifurcation, but I think it's not good idea. I think just the stent in the left side and balloon for the right side later. I know you intend to put the stent just above the bifurcation, but I don't think it's a good idea. I think the severe stenosis of LBA, and the first stent should still go inside the LBA, and you use a balloon for RBA. I think it's the best option.
After put the stent, so I will delete the stretch with balloon.
You can take pictures now. You can probably do some hand shot here.
Okay. Inject. Fluoro. Fluoro off. Play. What do you think?
Looks better.
Which wire do you choose to put the stent? The left one or the right one?
I think the left one is better.
The left one and just a little bit distal.
Yeah, right.
Not too much, just beyond the stenosis, just slightly, probably just one strap from the stenosis. That's just enough.
Ini yang mana tadi Dan? Saya kasih tanda. Oh itu Denny punya. Mana? Iya benar itu. Mana? Irama komputer. Pegang itunya supaya straight. Ups, ketarik. Wire-nya yang satu. Yang ini. Saya dorong dikit. Oke. Nggak kelihatan. Lampu please. Fluoro off. Oke. Nah ini berarti yang ini dia. Oke. Oke lah. Oke. Tahan. Ya. Yuk. Saya tahan. Oke. Take out. Ya. Fluoro off. Stand. Fluoro off. Yang mana, Den?
Pasang di kiri ya?
Kiri.
Kayaknya yang ini ya? Kiri, ini barusan kiri.
Coba, fluoro. Nah, ini clearin. Yang ini nih. Fluoro off. Kotor nih. Yang baru. Kelihatan? Oke.
Turun aja dok ya?
Nanti aja. Nanti belum masuk. Apa-apa kedorong. Sedikit. Ups. Terus. Seret. Because we use 5 French guiding, so it's a little bit
Woody,
yep.
When you rotate the guide wire, the left side guide wire, and so I think 2 guide wires maybe twist together, and you have some problem for putting the stent. And it's better if you cannot go with the stent, maybe you remove the right side or left, the right side guide wire first.
Sometimes it's entangled in your catheter. Dia berpulas-pulas di dalam kateternya.
Dapat. Ya, puterin ke sana. Udah masuk. Pegang. Hati-hati. Kenapa ya? Mentok ya. Lurusin. Dia bilang ini tarik dikit aja. Kenapa ya? Biasanya nggak gini. Fluoro? Masih?
Ini fluoro.
Oke.
Masih di fluoro nih.
Diambil aja.
Remove out. Yeah, remove. All right.
Enggak. Dikit. Bentar. kejauhan, tariknya dikit. PR-nya. Oke, injek dan. Injek. Udah gitu. Udah. Oke. Tuh. Ya. PR-nya tarik dikit kejauhan.
Inject lagi.
Injek.
I think it's okay now. We can inject now. Not too much outside.
Okay, inject.
Yeah, inject now. Yeah, I think it's okay now.
Ready to inflate?
Can you play again?
Fluoro off.
Fluoro off. Sudah selamat.
Injek.
Apa injek ulang ya? Injek ulang. Oh, oke, fluoro off.
Do you think it's enough for landing position? Or too much in left?
I cannot see.
Jalanin.
I think it's okay now, Budi.
Yeah.
I think it's okay. And when you inflate the balloon, the stent, just do very slowly. Make sure that the stent not slip to the distal bar or the proximal bar. And inflate very slowly.
Hisam, what do you think?
You probably need to expose the proximal shoulder a bit more.
So I pull a little bit.
Yeah, just slightly.
Okay.
Probably one strut away.
Oh.
Steady.
Steady. Cut it. Okay. Aja. Stop. Jangan didorong lagi.
Udah.
Fluoro. Inject.
Not the stent, the catheter.
Yeah. Okay, inject fluoro off.
Sini aja dong.
Yeah. Yuk.
Ask somebody magnify, make the bigger. A little bit too deep.
Jauhan. Ya. Inject lagi fluoro off dulu. Inject.
This is okay.
Yeah.
Okay, fluoro on.
I think it's okay, yeah.
Yes.
Budi, I
So,
think
yeah.
you should ask somebody zoom or make it magnify. I need the picture is a focus on the stent.
Sorry.
I think the
I
one
can
more
hear
zoom.
you.
Magnify the
Zoom,
angel.
okay. Fluoro dulu.
Yeah,
Okay,
right.
Inject dikit.
Yeah, very good. Okay, now.
Nice position.
Okay.
Yeah,
We will inflate the balloon.
Inflate very slowly.
Fluoro off dulu. Okay. Yuk.
Inflate slowly.
Slowly.
More. Yeah, right. Very good. Now inflate more. Wow, beautiful now.
10. Okay. Deflate.
10. Fluoro off boleh kan?
Off. Fluoro off. Safe.
Can you inject now before remove the balloon?
Inject.
Yeah, inject before removing the balloon.
Yuk.
No, the guiding should be closer.
Nearer, yeah.
Jar, ya. Deketin. Oke.
Advance the
Inject
guiding.
pakai tenaga.
Advance the guiding a little bit.
Lagi dikit. Deketin. Guiding. Inject then.
Yeah, right.
Okay.
Yeah.
Fluoro off. What do you think?
Cannot see.
I think the guiding catheter should close to the stent and enter again.
Okay. Fluoro deketin. Oke.
Yeah,
oke.
right, yeah.
Fluoro off dulu biar nggak terlalu itu. Oke, fluoro. Inject. Yeah, okay.
Very good now. And you can remove the balloon now.
Oke. Fluoro. Fluoro dulu. Saya mau tarik dikit ini. Nggak apa-apa. Kan dia masih panjang itunya, vesselnya. So the proximal part is bigger, and we don't have a stent more than 4.5. So I think one stent is enough, and the proximal part would not, close, yeah, on the PDA. What do you think? Hisam or Tin?
I think you can do angio and make the decision. But
Okay.
next angio, I think you should change angulation about 30 or 20 degree RAO. We want to see more clearly the RBA ostium.
Stop.
And so just change angulation to the RAO 20 to 30 degree.
Be careful when you advance the catheter, the guiding catheter, because it's very stiff and you have only single wire now.
Aparin? Ran? Itu beratnya 5 ya? 5 ya? 3.000? Sorry, pegang. Agak keras. Nggak apa-apa. Oke, dan tarik. Inject. Dorong dikit. Dorong dikit. Bentar, ininya. Ya. Lagi dorong dikit. Oke, stop. Fluoro off dulu. Oke, inject.
Buddy, can you wave?
Yeah.
Change to angulation to RAO 20 degree. You can see more clearly the RBA, the ostium of RBA. RAO.
Sorry.
You change
RAO.
Angulation.
Okay. RAO.
Yeah.
R berarti L. Harusnya di sini. Gak apa-apa, terusin aja dia. Udah.
Coba ya.
Cek.
Saya dorong dikit ada.
Boleh.
Catheternya harus dekat ya.
Oke, sebentar. Mulai ready to inject. Sebentar. Baru posisi. Oke, inject.
Fluoro off dulu.
Fluoro off.
Biar.
Inject.
Oke.
Sini.
Oh. Nah, aorta.
Dekat. Catheternya harus dekat dengan stent.
Dorong lagi dikit. Dorong lagi. Terus deketin.
Segini ya, Dok.
Oke. Oke, Dan. Lagi kontras. Lepasin ini. Yang ini lepasin. Saya pegang.
Ready? Nah, posisi dulu. Oke, dorong dikit.
Iya, dorong dikit. Terus. Oke. Injek, Dan.
Injek.
Sini.
Play, please. What do you think?
the guiding catheter is still outside the PDA, and when you
Yeah.
advance very carefully, because just the guide only very small the guide, and I see the RBA looks okay. No need to balloon in the RBA. It's acceptable.
Okay, inject then.
Yeah, but cine not cine.
Ah, do you want cine?
Yeah, cine. We can see more clearly.
Okay. Satu aja. Okay.
Yeah, it's a beautiful now.
Nice. How soon can you perform the surgery? Because this patient is already 5 months, right?
Yeah, maybe on 3 months to
Yeah.
6 months after stenting.
That should be all right. This one
How
should
to
last.
manage after we put the stent? Do you give heparin?
Yeah, of course, heparin
Yes, of
24 to 48 hours with a 10 to 20 unit per kg per hour. And aspirin
Yeah.
should be start earlier. And you see on the proximal part of the PDA, I think the stent good enough. No need to put the other stent or bigger stent. And
Yeah.
how about the saturation now?
Now increase to 90.
Okay, good enough. I think it's okay. Yeah.
Don't overdo it.
Okay.
And now
Thank you very much.
And congratulations on a very challenging case
Sorry.
and very difficult case for bifurcation. But Budi, they did very well and good result. And congratulations, Budi and the whole
Nanti
staff.
running dulu heparin. Heparin, ya. Per heparin baru kita tarik keluar stent. Kalau saya suka begitu, disimpan dulu aja. Di itu.
I would usually wait for 5 minutes,
kalau
then
ada
do another NGUY.
ngedadak
Just
itu
in
kita
case
masih bisa gampang
you
masuk.
encounter patient with acute stent thrombosis. That's my practice now.
Budi, I think you should remove the guide wire. The guide wire keep the long time, maybe the high risk for thrombosis.
Yeah.
Remove the guide wire now.
We just want to start the heparin, and then after heparin on, I will remove all.
Yeah, yeah.
Ya. Oke, ready, Keluar, yuk kita remove. Sudah ready, siap? Oke. Okay, finish. Thank you very much for your advice.
Congratulations, Dr. Budi. Halo, Dr. Tin.
Hai, Barus. Apa kabar?
Barus.
I miss you.
Any comment from Auden? Oh, Dr. Mahrus. Wah, apa kabar?
Good case, Dr. Budi. Nice case, ya. Dr. Marisam.
Ada komen, Dr. Mahrus.
Apa kabar?
Baik. Alhamdulillah.
Ya, tadi 90 saya lihat.
Sehat.
Alhamdulillah.
Besok.
I seldomly give heparin before the procedure. I give heparin after the procedure and continue with the infusion for 8 hours.
Maybe at least 2 days.
10 units per kg.
Yeah.
For 40 hours.
Yeah.
Masih ya? Oh, masih. Gak apa-apa. Tempelin aja. We start the approach from carotid, because I think from carotid is we can stenting the long tortuous PDA more easily and more visible, and also safe and with good result. We have a quite surprise, because you know, beautician is sometimes it's a lot of problem to perform in our hospital. regarding the ICU and so on. So I think approach from Carotid, collaboration with surgeon, I think we have more better risk to our patient.
And surgeon will do the cut down for you, and they can repair the carotid, right?
Yeah, surgeon. So I collaboration with surgeon, and then they cut the carotid, put the sheet, and then we perform the stent.
Okay, very good.
Yeah.
Very good.
We use the flip technique, so the head of the baby is just, you know, in first. The head is toward us, so the manipulation is more easy.
Yeah.
Good technique, good result.
Thank you.
Congratulations again.
Do you have anything else, Budi?
No, I think we have 4 cases today, so I think 3 more cases for standing. The second case is pulmonary atresia with intact pulmonary intact ventricular septum. We would like to perform from femoral. Actually, we have 2 cases with pulmonary atresia with intact septum, but the one I think have a problem with infection, just recent yesterday infection. So we put another IVS. Maybe later, if you still join, we can present the case.
Yeah.
Okay, thank you very much.
Okay, thank you. When can you start the next case?
After, I think after a few minutes after the first case, yeah.
Yeah. Okay, we will join the next slide case.
Any comment, Dr. Mahrus or Prof. Mulyadi, Prof. Sukman? Other province?
Dr. Budi.
Yeah.
Dr. Budi. Your stand size diameter is 4 mm, yeah. This.
Then yes, 4 mm, 12 in length.
Sometimes we found case that the proximal part of the PDA is more bigger than our stand. Is it the risk for thrombosis in the proximal of the PDA? The risk of thrombosis?
I think it's first we should consider the age of the patient. If below 1 month age, maybe we should cover all the PDA. But like in this case, the baby quite old. So, and the second is the proximal part is more than 5. So we don't have a stand bigger than 4. So we just leave the proximal part. Maybe Dr. Tin or Dr. Hisam would like add comment for this question.
Yeah, my talk previous my talk I mentioned about this the big ampulla with a small stent and maybe the high risk for thrombosis. And how to avoid this? We can put the bigger stent in the ampulla, the smaller stent in the pulmonary end. And also we should keep the blood pressure. It's not so low. I mean, avoid the hypertension. And also to keep the heparin and aspirin for preventing the thrombosis. And the main thing, I think, keep the blood pressure is high enough, and pressure gradient between the aortic and aorta and pulmonary artery is still high, and so it's a best way for preventing the thrombosis.
I tend to agree with Budi. I think this patient is already 5 months old. There's probably the risk of having constricted PDA probably not there anymore, and of course the risk of a thrombosis with big ampulla is there. But again, this is high pressure system. I don't think the risk of thrombosis is high in this group of patients. I think, and this patient is only for, this is already 5 months. I think she is already ready for the next stage surgery, probably 3 months from now. And this is requiring probably short duration of stent.
Mana? Mana So, see the camera. So, Dr. Hisam, this is our surgeon who have us to perform the procedure, and also the beautiful anesthetist, our anesthetist, Gazy. Yeah. I think with good collaboration, we can improve our service to our patient, I think.
Oh, very well.
Be close with your surgeon.
Yeah.
Any more comment? Maybe Dr. Rizky from Medan, Prof. Mulyadi, Prof. Sukman.
Lagi di jalan, Dr. Budi. Mohon maaf nih, lagi di jalan di bandara.
Many colleagues from all Indonesian, Prof. Herlina from Aceh, Medan, Rizky, Palembang, Dr. Yosi. Maybe you have experience to stand the duct. Any more comment? Eka from Bali. While waiting our next case.
Dr. Budi. Eka. Eka and
Henny from Malang.
Hi, Eka.
And a lot of colleagues from also from Vietnam, yeah, Tin.
Yeah.
I saw on the participant a lot of colleagues from Vietnam. Oh, Eka. Eka, do you have any comment?
I just wanna ask a question, yeah, about the experience with in 2 cases in here in Bali. I and Dr. Feni have done PDA stenting with 2 stent, by using a 2 stent, because of we're not sure about the occlusion of half part of the pulmonary artery branch. How about the comment? Yeah, maybe I need your comment, Dr. Budi or Dr. Tin or Dr. Riza, yeah, Dr. Mahruz, about how to use 2 stenting with the different stent in right pulmonary artery and left pulmonary artery with the different stent. Thank you.
Maybe Tin or Hisam.
Yeah, you can see the similar Budi case. He just done the case. If the RBA very stenosis and just osmium, we don't need to use a stent. You just use a balloon. But a long segment RBA or LBA stenosis after the first stent, and I think you should use the second stent. The second stent similar to use a balloon for open for dilatation the branch of the pulmonary artery. And the problem is the way we put the second stent. The second stent just very short, not too long. First one. Second one, not to protrude too much inside the first stent. And so the very short and big enough the stent is most important. And the technique, I think no problem for all of you. Just put the second stent and you and just make sure that we are the right position of the second stent compared with the first stent and the pulmonary artery also.
I will see the physiology of the patients. If the patient is in two ventricle physiology like TOF pulmonary atresia or TGA, TGA VSD pulmonary atresia, who require probably Restali surgery, it's probably very easy to make decision. Put in the stent, second stent, third stent, doesn't really matter because I think the surgery is probably more straightforward. But for those with single ventricle physiology, like Glenn shunt surgery, I would try to restrict myself from putting in the second stent. I would just prefer put in one stent and either open up the strap into the opposite pulmonary artery and closely follow up the patients and prepare the patient for the next stage surgery.
Thank you, Dr. Lisa. Thank you, Dr. Tin, Dr. Budi. Maybe in what I mean with using two different stent, yeah. I mean that we use right pulmonary artery stent and we use two left pulmonary artery stent too. If we find that the pulmonary artery case is without the main pulmonary artery, how about if we use two different stents in right pulmonary artery and left pulmonary artery?
So you mean, Eka, you put the stent from the duct until left and right pulmonary artery?
Yes, yes, two different stents in right and left pulmonary artery.
So what do you think, Tin? Hisham?
I think it's okay, no problem, Eka, you can do this.
Okay, thank you.
My opinion is still the same. If patient is TOF pulmonary atresia or patient's two ventricle physiology, your surgeon can do good repair. Yeah, go ahead. You can put in the second stent. If the stent stenos, then you could put in the third stent in the future while awaiting patient for corrective surgery.
How long the maximum time, Hisham, for next surgery after put the stent on the left and right pulmonary artery?
Because in two ventricle physiology, I think the surgeons can do good repair, and this is high pressure system. The growth of the pulmonary artery will not probably affected too much, even though if there is any, you can probably put in pulmonary artery stent in the future. But for single ventricle physiology, for surgeon to reconstruct pulmonary artery with too many stents inside is probably a bit difficult. And from literature, I think a lot of issues that are highlighted after the stenting procedure, especially when we use too many stent materials. The PA reconstruction will probably be a bit difficult. And Glenn shunt is very low pressure system. So the growth of the pulmonary artery will not be satisfactory, and you may need to follow up, and you may need to probably stent the pulmonary artery after the surgery.
Oh, okay. Eka, are you happy?
Yeah. Thank you, Dr. Hisham, for your comment. Maybe will make our knowledge will be increased. Thank you.
Maybe other comment from other college. Prof. Sukman, Prof. Digdo, Ruby. Any comment, Dr. Ruby?
One other thing, Dr. Budi.
Yeah, please.
About the access in your case, you use the carotid artery, yeah, to make the access. How about the bleeding after we pull out the sheet? Is it possible to make the bleeding stop with the push this pull, like if we use the other access from axilla or femoral?
Yeah, we don't have any bleeding case after approach from carotid. I think our surgeon will answer more detail about this if you want to hear. Nafi, ada pertanyaan tuh, gimana caranya supaya nggak bleeding? Nih, jawab ini. Dilepas dulu. Oke.
Okay. So we did a good identification for the carotid artery. Lepas. Okay. And then I'm doing a primary suture for the puncture. So we make sure there is no dissection and there is no bleeding. And then for the control of the distal and proximal, we did the control of distal proximal because the patient is small. So we use silk for the control. We use a loop silk, and then for the during the primary suture of the puncture, we the airing as well. So most of the time there is no problem with the airing. There is no stroke incidents, hopefully in the future. Thank you.
Yeah, thank you, Nafi. So I think we have work as a team. So I think it's more better, yeah. So what do you think, Tin? And also Hisham?
I think basically for the carotid approach, I think the surgeon's view is basically much clean and less bleeding compared to our approach. We have punctured a lot before getting the lines, unless you can get it at one go. But surgeons has opened up and they have control in terms of bleeding, and they can control bleeding. I mean physically, not they can see this is their visual, and they probably can tackle all the bleeding precisely, as compared to the interventionalist, which is we probably just cannulating. If good now to start practice using vascular probe, if you have any, to prevent all these bleeding issues.
I don't think it's a good idea for removing the sheath and compress on the carotid artery. It causes a high risk for thrombosis and stroke. And the surgeon, they can do better than us, much more better. And you should ask them if you intend to do the carotid approach. If a femoral and auxiliary we can do, but carotid, I think the surgeon better.
Yeah.
I want to ask the experience of from Dr. Tin or Dr. Marisam about using brachial artery for stenting the vertical PDA, vertical duct.
I didn't do the carotid because my surgeon is so busy. They,
yeah. The problem.
Your experience
surgeon always busy.
Brachial puncture.
Yeah, most of case I prefer to use a femoral artery approach, and I think all of us very familiar with a femoral artery approach in not only PDA stenting but also other procedures. And the problem for vertical PDA, we use a cut detail to approach and crossing. I think it's my technique for the approach the PDA and PDA stenting.
Yeah, my preference is always auxiliary.
Even for vertical duct, can you approach from femoral?
Of course, we use a cut detail with a different curve. You can approach easily, and you can see the angulation between the arch and the PDA, and you can cut the pigtail accordingly.
What size of pigtail, Tin?
4 French. 4 French is soft enough and small enough. I think 4 French is okay. No,
but 4 French just to manipulate the guide wire.
Yeah, right.
The problem is while you exchange the cut pigtail with GR guiding, it's the wire is easily pulled out to the aorta. How to engage the what's called the wire, coronary wire, when you exchange the cut pigtail with GR.
Yeah, but most of cases the baby very small, and we have no problem with the length of the guide wire. The coronary wire is long enough for exchange the catheters. Because very small baby, and we can remove the pigtail without any.
I know what Budi means. I think you can advance the coronary guide wire into the PDA using the pigtail for French cut pigtail. But again, once you want to deliver the stent, you need to change to guiding catheter. So this is where your guide wire might not be adequately anchored and is come out from the PDA, and you have to start all over again.
Yeah,
I would still prefer if auxiliary is approach, because I think is can provide you a straightforward PDA stent procedure. Carotid I reserve only for those with very vertical and tortuous PDA, and of course you need to work out with your surgical colleague. But now I think we do more and more auxiliary approach. Or if the vertical PDA, another option is basically venous trans VSD PDA for 12-month atresia.
Yeah, the problem is from transvenous is frequently we deal with half-way block.
Yeah, half block.
During the catheter crossing the VSD to the aorta.
Usually just during manipulations. Once you cross into the aorta, it goes off. It's only when during the advancement of the catheter.
Yeah. So Tin, when as Hisham mentioned that if we use cut pigtail to cross the vertical duct and then exchange with GR, because the curve of the GR is different with cut pigtail.
Yeah.
And it's 10 you know, to go to the proximal part of the aorta, the GR, and then also the coronary wire.
Yeah.
That's a problem in transfemoral approach for vertical duct stent.
Yeah. And also you're right. The angulation, the angle of the catheter and the JR guiding catheter is quite different. And so normally the main thing is how to fix the guide wires as far as possible. And I normally anchoring the guide wire by twisting the guide wire and makes the loop inside the distal bulk of the pulmonary artery. And the guiding catheter, I don't try to push very close to the inside the duct, because we will lose the guide wire. And just close to the duct and advance the stent. When the stent inside the duct, we can advance the guiding catheter maybe easier, because with the stent, the guiding block enough for the putting inside the PDA. And don't try to put the guiding catheter inside the PDA, just only the guide wire. We will lose the guide wire.
Okay.
Another trick, maybe you can probably bend the catheter before you advance.
Normally, I paint the catheter with hot water.
Yeah.
Yeah. Okay, any more comment from audience?
Hello.
Any question you can
Hello.
ask to Dotin or Hisam.
Prof. Mulyadi, Dr.
Prof. Mulyadi, yeah.
Budi.
Hello, Dr. Tin, Dr.
Panggil dari
Maisam.
tadi. Ada.
Sorry, I just finished doing intervention. Yeah. Sorry,
yeah.
I did not follow through the procedure of the Dr. Budi. Good luck, Dr. Budi. Yeah, Dr. Budi ini is one of the interventionists, yeah, who done stent in Indonesia. Yeah, very much, Dr. Budi. Yeah, almost every day. Yeah. Dr. Tin, one question for you. Yeah, do you routinely done balloon? Yeah, before you put the stent. Yeah.
Oh, no. Just some special case, some select case, such as the Budi case today. The LBA is so stenotic. He tried to put the stent with through the guide wire, LBA guide wire, and he had some problem for advance the stent to the PDA. And in this kind of PDA, some very sharp angulation and stenosis, we prefer to use the balloon, just open the ostrum and for crossing the stent easier.
Yeah. From angiogram, what is the guiding that you have to do balloon? Because I've experienced at the time very difficult to push the balloon stent, because the PDA very tortuous. And then when we pull, yeah, and the stent slip to the PDA, and we only pull the balloon. Yeah.
And so it's we say the defox from the balloon and the stent.
Yeah. When I pull the balloon, yeah, with catheter, yeah, the stent left in the PDA. Yeah.
And what did you do when the balloons are outside the stent? How can you do?
I sent to the surgeon. Yeah, because this is yeah, they slip the unloaded stand. Yeah, stand still collapse, and I've difficulty to retract the stand. Yeah, the undeployed stand. Yeah. And then because the patient saturate or the student become low, and I said to the surgeon to do bitisan. Yeah, bitisan situ.
Yeah. And our colleagues, I mean the coronary staff, also have some problem when they try to do with the coronary intervention with calcification. Also, they have some problem with the balloon and stent. The balloon outside the stent, and it's a big problem for the.
Yeah. Do you have experience, Dr. Tin?
Yeah, I have several cases. The balloon just outside the stent, and I try to if any balloon inside stent, I inflate the balloon now, and with inflate the part. The balloon, the part of the stent, the proximal part of stent will be open, and deflate the balloon and advance more, and we can open the stent, fix stent first, because if the stent move somewhere, the surgeon also very difficult for remove it, and I fix the stent. Normally the stent inside the BDA, and we open the proximal part first, and deflate the balloon and advance a little bit, or change to very small balloon and open open the stent again. I did several cases. Luckily, all the case successful.
Yeah, at the time I very difficult to manage to retract the stent, the undeployed stent, yeah. And then finally the wire slip. Yeah. So I concluded to send the patient to the surgery.
Yeah. And so the wire is the most important. You should keep the wire. If the wire, you lose wire, you lose everything.
Yeah.
Excuse me,
Finally, I lose the wire.
Just a brief interrupt. Navi will show the puncture area and explain.
Okay. I just want to show that we use a Langerhans line incision for the puncture area. With normally carotid incision is it's vertical longitudinal to the sternocleidomastoid, but we use a different approach. We use the Langerhans line, so we can see that the incision will be on right in the crest of the neck. So the sutures won't the wound will be very good. There will no sign of any wounds in the future, hopefully. Thank you. Just that I want to say. Thank you.
Yeah.
Oh no.
Okay. So this baby head is here, and the foot is over there. This is a flip technique.
Yeah. Very good. Very beautiful.
Please continue about comment, Dr. Pramul.
Dr. Budi, who closed the site of the puncture in the arterial, in the carotid? Dr. Budi.
Maybe you not follow the case. They use a cut down with the surgeon. And the surgeon when remove the sheet, surgeon also they make the books before putting the sheet, and when they remove the sheet, they just stick the books, the live books, and close everything. And the surgeon they did very well, and Budin has no problem for puncture, for removing the sheet.
How about if we just press like other?
No, we cannot press on the carotid artery because a high risk for thrombosis and stroke. It's a high risk on the risk.
Oh, high risk,
yeah. If we intend to approach carotid approach, you should ask the surgeon.
How about in the axilla? Do we have to send to the surgeon also?
I think my has many experience. My has many experience on the artery.
Yes, I think as I mentioned before, I think for I would prefer axillary artery for type 2 or type 3 duct. Okay, and if let's say sometimes because you have to cannulate yourself. Now we have started our vascular probe program. I think with the assistance with vascular probe, I think you should be able to to get this cannulations easily. You have to make use of the vascular probe, and sometimes you can do the guide wire technique from the femoral, pump the coronary guide wire into the axillary artery, and you can puncture using the wire as a guidance. And I think the axillary artery approach is probably much better in terms of technicality, direct approach into the PDA, and for the stent placement, as compared to a femoral approach for the vertical dart and also type 2 or type 3 PDA. I only use a femoral approach for those with type 1 PDA, which is the PDA arising from the descending aorta into the pulmonary artery, or those with type 4, the subclavian arising from the subclavian.
Do you have any complication for the auxiliary approach? I mean the bleeding or the thrombosis or some problem, complication?
Now we are in the midst of the study of axillary artery stenosis, and until now we have not seen any significant stenosis of axillary artery. And we do have one patient with bleeding, hematoma, probably not well sealed after the compression. In one case with acute stent thrombosis. So I think it's more stent-friendly approach. Does that answer your question?
Yeah. And Budi, any comments, or we can move to the other the next case? And I think we should, or after comments, we should congratulations Dr. Budi and team again for the last previous case.
So this is the previous patient.
Looks very pink.
I would congratulate your team because you extubate on table. This is unlike in my institution where we extubate patient in ICU. Good job.
Yeah, because we have limited ICU bed, so we should extubate on the table if possible. But if Gezi do that, I think it will possible. Gezi. Thank you, Gezi.
You have a very good anesthesia backup.
Say hello to Vietnam and Malaysia. Okay, we will prepare next case.
I think we will back to you the next day. I should leave now.
Yeah, okay. You
Me
may
too.
join after break maybe. If you able to join, yeah, we will wait. But if you have anything to do, so I think it's okay. Hisam, thank you, Hisam.
All right. Thank you, Budi, for the invitation, and thank you to be part of this exciting meeting. Right.
Get well soon.
See you in Bangkok next month.
Yeah.
Next 2 months.
Yeah.
Bye.
Bye. Thank you,
Bye,
Hisam.
madam. See you in
Regards to
Bangkok.
your colleagues in IGN, Dr. Mazni, Dr. Hasri, and yeah.
Sure. Yep, I will. Okay, Tin. Thank you, Tin.
Kameranya di jalan video.